I don't have any 12-lead ECG for this. But this is, the QRS is 0.18 seconds for the duration here. And there is a fusion beat. So that's a fusion beat. And that's a fusion beat there. So if you look at that lead 2 of SVT, there's no fusion beat. It's purely all narrow. This is artifact, so don't worry about that artifact. Disregard that one. There is an SVT with the right bundle here. If you look at V1, it is upright. So let's go with the SVT with right bundle. That is triphasic. There's an RSR. There is an R is R, but it's kind of small here. But there's an R, there's an S and R. So that's the RSR. If you look at V6 here, it's upright. And if you look at this one, we have here an upright. But the rate here is fast. Okay, so this is just to show you. That's it. So that is SVT with right bundle branch block. We have an AFib with Wolff Parkinson here. So if you say SVT, but I see it's AFib, I will go specific to the point. This is AFib with Wolff Parkinson White syndrome. So there are wide complexes in here. So you look closer in here and you see there is a delta wave. So as I said earlier, impulses can come from the SA node or from the atria. They cross the AV node in here, and we have all the bypass track in here. That's what, so it's faster. Okay, so in here, we have here a delta wave. So that points that we have a Wolff Parkinson in this patient. Okay, so this is AFib with Wolff Parkinson White syndrome. If you look at this rhythm here, it's wide complexes here from V1 to V6. It's negative deflection, it's wide, and it's wide. Looking at your SVT, it's wide and it's wide. Left, V1 downward, upward, RSR. This one is typical of that. And we have here, okay, negative deflection. And we have you have here an upright. So we look closer, the patient is talking and everything, fine. Then we dig the blood works, the potassium is 6.5. So we don't want the patient to end up, we don't want the patient to go into VTAC. So the best thing to do is treat the cause. And hyperkalemia is the cause. So we either give K-oxalate and excrete, we give K-oxalate, which is a binder to the potassium, and excrete that potassium with the feces, or we either give D50 with insulin and put back this potassium inside the cell. Okay, so so if you happen to see a wide complex tachycardia, the best thing to do, the technique there, the best thing to do is the patient tolerating it. If you see the patient is in wide complex tachycardia and turning cyanotic, losing consciousness, and also losing pulses and everything, of course. So the only thing you could do is don't look at the criteria of VTAC. Go attend to the patient's problem right away. Don't waste time. And all you have to do is lie the patient flat on its back with a hardboard, do the CPR, and somebody has to grab the crash cart with the defibrillator and defibrillate the patient right away. You attend. When there's a shockable rhythm, we have to be thankful, okay? So we're trying to chase those rhythms, either VTAC or BFib. But don't let that BFib to end up in systole, because you cannot defibrillate a systole. All you have to do there is CPR, and you'll end up giving epinephrine to create, a rhythm that you can shock. We don't want that thing to happen. So with SVT and everything, if they are conscious, talking and everything, and it's wide complex tachycardia, you can always compare with the previous ECG, or request for an ECG to be done because the patient is still tolerating it anyway, and look closer, is it VTAC or SVT? Okay, so that's about it, guys, and the next video will be about management. There will be pharmacology and some nursing aspect with wide complex tachycardia. Okay, thank you so much, and if you think this presentation is helpful, you're welcome to press like, share, and subscribe. Thank you and have a nice day. Bye-bye.